Welcome to The Explainer. We're diving straight into a topic today that is just as complex clinically as it is demanding on the administrative side: precision ICD-10 CM coding for HIV and AIDS. If you work with medical records, you already know this isn't just about punching in alphanumeric strings. It's really about accurately translating a lifelong clinical narrative into data.
Imagine this coding puzzle for a second. Once symptomatic, always symptomatic. Picture a patient who battled severe HIV-related illnesses years ago, but today they're sitting in the exam room feeling perfectly fine with a totally undetectable viral load. Do you code them based on the healthy person sitting right in front of you today, or the profoundly sick person they were 5 years ago? Keep that puzzle in the back of your mind, because the answer literally dictates how we approach this entire specialty.
Here is our roadmap for today. First, the stakes of HIV coding. Second, decoding the core codes. Third, navigating the edge cases. Fourth, key clinical documentation elements. And finally, a real-world coding example.
All right, let's jump into Section 1, the stakes of HIV coding.
Before we even think about touching a single ICD-10 code, we have got to establish our clinical baseline. In coding, we're dealing with a massive clinical spectrum. On one end, you have an asymptomatic infection, meaning the virus is present, but there are absolutely no symptoms. On the extreme other end, you have acquired immunodeficiency syndrome, or AIDS, which is characterized by serious, often life-threatening opportunistic infections. Our main job as coders is pinpointing exactly where a patient sits, or historically sat, on that spectrum.
So, why are we so obsessed with getting this clinical picture perfectly right? Well, the codes we select go way beyond basic billing. They actively impact treatment decisions made by other providers who are reading that chart. They drive proper reimbursement for some incredibly expensive specialized care. They feed into massive quality measures, and above all, they demonstrate the medical necessity for the complex interventions these patients are going to require over their entire lifetimes. The stakes here are just incredibly high.
Moving right along to Section 2, decoding the core codes.
Okay, it's time to open up the official rulebook for the ultimate coding matchup you are going to face every single day. On one side, we have code B20 for HIV disease. This is your primary code when a patient has a symptomatic HIV infection or has ever been diagnosed with an HIV-related illness. And I really want to emphasize that word ever. Even if the patient currently has an undetectable viral load because their treatment is working perfectly, that viral suppression does not change their coding classification. If they have a history of HIV disease, boom, they get B20. Now, on the other side, we have Z21, which is for asymptomatic HIV infection status. You use this strictly for a documented HIV-positive status where there are absolutely no documented symptoms or HIV-related conditions past or present. If the doctor just writes HIV-positive with zero evidence of symptomatic disease, you go with Z21.
And just a quick note on R75. Think of R75 as your temporary placeholder. It's only reported when laboratory testing comes back indeterminate or inconclusive, and you only use it until a definitive diagnosis is actually established.
Let's dive into Section 3, navigating the edge cases.
Since we all know medical coders absolutely love edge cases, exceptions, and finding reasons to query doctors, let's take a look at our secondary toolkit. While B20, Z21, and R75 are your heavy hitters, you're frequently going to need these secondary codes to tell the whole story. For instance, Z11.4 is for routine screening without a confirmed diagnosis. If the patient specifically has HIV-2, you'd add B97.35. We've also got Z20.6 for known or suspected exposure and Z71.7 for counseling. And definitely pay attention to the medication codes. Z29.81 covers an encounter for PrEP, while Z79.899 covers other long-term current drug therapy, like when they're managing asymptomatic HIV with antiretrovirals. But wait, before you use any of those primary disease codes, you absolutely must remember this immovable law straight from the 2026 ICD-10 official guidelines. You may report only confirmed cases of HIV infection.
Now, this is a massive deviation from the norm. Normally, if a patient is admitted to the hospital and a condition is documented at discharge as suspected or probable, standard inpatient guidelines say, sure, go ahead and code it as if it exists. Not with HIV. HIV requires strict provider confirmation. However, and this is a really crucial distinction, confirmation in the context of HIV coding does not mean you, the coder, have to go digging through the lab records playing detective to find positive serology results. The provider's diagnostic statement that the patient is HIV positive or has an HIV-related illness is completely sufficient for code assignment. If their statement is fuzzy, you query the provider. Speaking of edge cases, there's actually a fascinating sequencing rule here. Generally, when a patient is admitted with an HIV-related condition, B20 is reported as the principal diagnosis, right? Followed by the codes for whatever the associated conditions are. But there is one very rare exception: hemolytic uremic syndrome associated with HIV disease. If that is the reason for admission, you actually assign code D59.31, infection-associated hemolytic uremic syndrome, first, and then you follow it up with B20 as secondary.
Which brings us to Section 4, Key Clinical Documentation Elements. Ultimately, our codes are literally only as good as the clinical notes backing them up. To support assigning B20, the provider's documentation has to clearly establish a direct relationship between the patient's HIV infection and the condition being treated. It is not enough that the patient just happens to have both at the same time. Classic opportunistic infections, things like recurrent pneumonia, tuberculosis, Kaposi's sarcoma, severe herpes simplex, or candidiasis, must be explicitly stated as HIV-related by the provider in order for us to correctly sequence B20 alongside those manifestation codes.
Now, in the world of HIV documentation, there is one critical numerical threshold you always need to be scanning for in lab results and clinical summaries: 200.
This refers to the patient's CD4 cell count. To put that in perspective, a normal, healthy CD4 count sits anywhere from 500 to 1,400 cells per cubic millimeter of blood. But in folks who aren't receiving antiretroviral therapy, those vital immune cells are progressively destroyed by the virus. When that count drops below 200, the physical reality is that their immune system is severely compromised. They become highly susceptible to that wide variety of opportunistic infections we just talked about, many of which can be rapidly fatal. So tracking and documenting this drop is a huge indicator of disease progression.
It's also absolutely crucial that providers are rigorously documenting lifestyle risks and treatment regimens. We're talking about things like unprotected contact, shared needles, or occupational and perinatal exposures. Now, while those risk factors might not always change your primary diagnosis code, they provide vital clinical context, and they can definitely support exposure-related secondary diagnoses. Just as importantly, providers have to document all antiretroviral regimens and prophylactic treatments. Detailed treatment documentation clearly supports medical necessity, and it proves the ongoing intense management required for patients living with HIV.
Let's bring it all together in Section 5, a real-world coding example. Time to put on our detective hats. Here's the scenario. We have a 55-year-old patient with end-stage renal disease who comes to the hospital because they've got the flu. The patient has a past medical history of HIV disease and is currently taking antiretrovirals. Digging into their history, we see they previously had a CD4 count of less than 200. However, the provider's current diagnostic statement lists HIV disease on ARVs, CD4 is 335, and viral load is undetectable. So here is our roadblock. This patient looks clinically stable right now regarding their HIV. What on earth do we code for their HIV status?
Okay, let's think this through logically. Step 1, we note the current state. The viral load is undetectable, and the CD4 has rebounded to 335. Like we said, they look pretty good on paper today. Step 2, we look at the history. The documentation clearly states a past medical history of HIV disease with a historical CD4 drop below 200. They have undeniably had symptomatic disease in the past. Step 3, we apply that core ICD-10 CM guideline regarding HIV disease history. This brings us to what I call the one-way door rule of HIV coding. Once a patient has progressed to symptomatic HIV disease and has been assigned code B20, they walk through a one-way door. They can never go back. That designation remains applicable for all future encounters forever. And therefore, our final code is absolutely B20. And this is explicitly confirmed by the AHA coding clinic in the fourth quarter of 2020. Improvements in clinical status, incredible viral suppression from medication, or the total absence of current HIV-related symptoms absolutely do not change this classification. You cannot code this patient with Z21 even though they are clinically stable today. Their historical symptoms dictate this code for the rest of their life.
And that wraps up our explainer. But before we go, I want to leave you with one incredibly important question to reflect on. Take a look at your own charts this week and ask yourself, does your documentation truly capture the lifelong clinical picture of HIV? Because remember, in medical coding, a patient's history doesn't just disappear when their symptoms do. Thank you so much for hanging out with me to decode this critical topic, and I'll catch you in the next explainer.